So everyone, thank you so much for joining us for NAMI's Maryland's 40th annual conference. My name is Diane Sabal, and I'm a volunteer at NAMI Maryland, and I'm going to be your moderator for this session today. This workshop session is entitled Current Best Practices in Psychosis and Schizophrenia Spectrum Disorders, and it's going to be presented by Dr. Stephanie Kulaga from the University of Maryland. You can read more about her and our other amazing presenters, including their full bios, in the digital conference program on the official conference website. So this presentation is going to provide an overview of the different types of treatments currently indicated for psychosis and schizophrenia spectrum disorders. It will cover the use of different medication classes, management of side effects, and concurrent use of non-pharmacologic interventions. The aim will be to help patients and families understand why and how different treatment methods are used and offer providers a review of the current evidence on best treatment practices. So if this is not the workshop you meant to attend, just click the back button in your screen or your browser and click on the sessions button on the left-hand side, and you'll get returned to the full list of workshops that are available. And we are going to be addressing questions at the end of this presentation. So if you have any questions as the presentation is ongoing, please post them in the Q&A section. You can see that there's 4 tabs to the right. One says chat, polls, people, and Q&A there. And we're going to be reviewing the questions as they come in. And if something in particular is unclear, needs to be explained, we'll ask our presenters after their presentation has concluded so we don't really interrupt them. And we're also pleased to offer closed captioning for this year's conference. And captioning is only available for attendees if you're using your desktop, okay? So just keep that in mind. And to enable captioning, what you do is you click on the CC icon below the display of our presenters at the bottom of your screen. And once you click the icon, the video displays will become smaller and you're going to be able to see the captions being generated underneath. So if you also have any comments, concerns, or technical issues, you can also post them into our chat, and our technical assistant, Camille, here is going to address them accordingly. So without further ado, I'd like to now welcome our presenter for today's workshop, Dr. Stephanie Kulaga.
Hi. All right, I'm going to play this now. It's always weird because I can't see anyone when I have the slideshow up, but thank you so much, Dan, for that introduction, and I'm really excited to be here today. This is my first time coming to a NAMI conference, but I've been familiar with their work for a long time, so yeah, I'm just really happy to be here. And also, thank you for coming on a Saturday afternoon. You've made it to almost the end of the conference. So just quick intro. So I'm Dr. Stephanie Kulaga. I'm a 4th-year psychiatry resident at the University of Maryland. So that means I'm a doctor doing my specialty training in psychiatry, and I'm in my final year of that. I also do some research at the Maryland Psychiatric Research Center. So you may have seen some of Dr. Deanna Kelly's talks yesterday. I do some work with her. This is where Dr. Rachel Adams works. She did the talk yesterday on CBT for schizophrenia and schizophrenia spectrum disorders. So I have no financial relationships or conflicts of interest to disclose. And these are the learning objectives for today, to identify different classes of medications used in the treatment of schizophrenia spectrum disorders, to describe the relative benefits and risks of different pharmacologic treatment approaches, understand the factors taken into consideration when choosing a particular treatment strategy, and to broadly describe the non-pharmacologic treatments used in psychosis and schizophrenia spectrum disorders. So I'd like to first start out by talking about what do I mean when I say schizophrenia spectrum disorders or schizophrenia and related disorders. We have this huge list of disorders here on the right that includes schizophrenia, schizoaffective disorder, delusional disorder, briefer types of psychotic disorders, and then there's this category in the DSM, which is the Diagnostic Manual for Psychiatry, of other or unspecified psychotic disorders, which is really anything else that doesn't fit into the criteria for these categories. Today, I'm going to say schizophrenia most of the time for simplicity's sake and kind of talk mainly on treatments that focus on that. But these are disorders that are kind of in the same class. And so basically some of the treatment modalities that I talk about today might be used in some of the other disorders you see on this page. So just to kind of make sure we all know what we're talking about.
Dr. Kalaga, don't mean to
Yes.
interrupt you. Some folks say that they can't see the slides. If you can put it in slide presentation, I don't know if you're in slide presentation yet.
Can you see it now?
So Catherine and Yvonne, can you see your slides? They said not yet. Both say not yet. Just a black screen. So Myra can see, but Catherine, Kevin, and Yvonne say no.
Huh. Let me close this. And then let me try again.
Okay. And so a lot of folks are saying that they can see. So Catherine and Kevin and Yvonne, that might be an issue in you guys. And most of the folks can see.
Okay.
Okay, so we'll try it again.
Okay. How are we doing now?
Okay, now they can see the slides. Okay.
Awesome. Thank you for chiming in and helping us fix that.
Yep, not a problem.
So again, because I'm going to mostly be talking about schizophrenia, specifically, I just have the diagnostic criteria here. And some of you may be familiar with this already, but we'll just go over briefly. The criteria are that a patient will have 2 or more of the following symptoms for most of the time during at least a month period of delusions, hallucinations, disorganized speech or behavior, or something that we call negative symptoms, which we'll talk about in a moment. And then that the level of functioning would be impaired in at least one area of life, like work, their interpersonal relationships, or self-care. And this would all be going on for at least a period of 6 months. However, I'm going to go ahead and say I don't really care a whole lot about diagnoses and diagnostic criteria because schizophrenia is really more of a syndrome than a disease. I think Dr. Kelly alluded to this in one of her talks yesterday, if any of you attended that. But I bring this up because usually when people come to the doctor, they go, they expect to kind of get diagnosed with a disease that has a particular cause and then a particular treatment that will help it. And so here I have definition of a disease is an abnormal condition that has harmful effects on structure or function. A disorder has to do with impairment in function. But then there's something called a syndrome, which is a little bit different. So syndrome is a group of symptoms that together are characteristic of a specific disease or disorder, but they might be caused by several distinct or interrelated processes. So I go into this just to say that schizophrenia or a schizophrenia spectrum disorder does not look the same in every single patient, and that's why it can be so difficult to treat. We think that all of the people who have the diagnosis of schizophrenia don't necessarily have the exact same thing. They have something that presents in similar ways, and they have similar problems and symptoms because of what's going on, but we really think that it's probably a group of disorders that are interrelated in some way. And so these are the features of schizophrenia as we're thinking about it as a syndrome. So there's both negative symptoms, positive symptoms, and cognitive symptoms. Positive symptoms are kind of a misnomer. So it doesn't mean positive as in like it's a good positive thing. It's positive as in it's kind of an additive experience to what someone would be having at baseline. So when we talk about positive symptoms, I'm referring to hallucinations and delusions. So people having intrusive sensory experiences, beliefs that might not have a basis in reality. And hallucinations, the most common thing people think of is like hearing voices, for example, but these really can manifest in a broad array of presentations. Sometimes people will describe something called like a felt presence, where they might have a sense that someone's in a room with them. They might hear voices, they might hear sounds, they might have other kind of perceptual disturbances that might be difficult to describe or even understand. And so from a provider standpoint, I always think it's really important for us to remember that the things that we screen for on a checklist are really just a tiny, tiny sliver, like the tip of the iceberg of all of the distressing things or intrusive things that a person might be experiencing. And so it's always really important to understand that, we might not have the whole picture, and we want to really be open-ended and curious when we talk to folks. The negative symptoms include things like social withdrawal. So people might become really isolative with this disorder. They might experience emotional blunting, kind of having what we call a flat affect. They might have kind of a lack of speech. It might be difficult to have them elaborate on certain things, just kind of a decrease in the amount of speech production, and then a decrease in motivation and goal-directed behaviors. So these things can really get in the way of people living their lives and doing all of the things that are meaningful to them and that they want to do. And then the third domain of symptoms are cognitive. And so those with a schizophrenia spectrum disorder may have problems with memory, attention, executive function, and then social cognition. And these can also be a domain of symptoms that can really cause a lot of impairment in functioning. And then again, when I was talking about a syndrome does not have one specific cause. And so this is just kind of a graphic to show a lot of the different things that can contribute to the development of schizophrenia. So people might have genetic risk factors, but there isn't any one particular gene or group of genes that causes the disease. We just know that there are some genes that are associated with having the disease. Substance use is a big risk factor, particularly hallucinogenic substances, and cannabis is a major risk factor. Things that happen during pregnancy can increase risk. So for example, there's been a lot of research about influenza infection during pregnancy, and there's studies from flu pandemics in the past showing that people who were born during those times had a higher risk of schizophrenia, because when mom has infection during pregnancy, it can expose the fetus to inflammation, and that can change how the brain develops. People who have infections really early in life can have similar risks from that. Epigenetic changes are changes that happen to our genes after we're born. So our genes are kind of the blueprint for all of our cells and proteins and things in our bodies. But that blueprint actually can be altered if things happen like an infection or a lot of stressors. Trauma, just psychosocial stress, having undergone, any sort of like physical trauma, emotional trauma, and then hormonal changes can also have some effects. Particularly in women, we see that age of onset is usually in early adulthood for both men and women, but there's a second wave of onset for women around menopause, which is thought to be due to the changes in hormones at that time. And so someone who has schizophrenia may have one of these risk factors, all of them. Someone who has all of these risk factors might not necessarily have schizophrenia. And so this is just kind of to get the point that there's not really a simple singular cause that we know of, and that's why there's kind of not a simple singular treatment for this. This is just a brief slide mentioning some of the sex differences. So for people who have male sex assigned at birth, the age of onset tends to be a little bit earlier, in the late teens to early 20s, versus female sex, late 20s or midlife. And then there's some differences in symptoms between male and female people. So more negative symptoms we see in men, and sometimes in women more mood symptoms, maybe slightly better prognosis in women. But again, all of this is kind of on average. So now that we've kind of talked about what it is that we are trying to treat, I want to talk about what are the goals of treatment. And so really the ultimate goal of treatment is better quality of life, a reduction in suffering and a better quality of life. And what that means is defined by the person who's guiding the treatment. How we get there, there's a couple different steps. So since I'm a physician, I'm going to focus a lot today on talking about medication, and I'm not going to get into a lot of super specific different med choices or in-depth pharmacology. I kind of just want people to have a broad overview of why we might choose some meds over others, and what role medication plays in the overall picture of treatment and recovery, because it's just one part. And so the medications that we do have are best for alleviating the positive symptoms, those delusions, hallucinations. And so the general kind of idea is that we use the medication to stabilize someone who's kind of having an acute psychotic episode. they stay on those medications to control those symptoms, and then that allows them to engage in things like psychosocial treatments, therapy, maybe get back to work or doing things with family, and all of those things can help improve their functioning and sometimes help improve some of the negative and cognitive symptoms. Other aims of treatment are to reduce medical comorbidities, because people with schizophrenia do have a higher rate of medical comorbidities, and related to that, unfortunately, a decreased life expectancy, and then also to prevent suicide. So in talking about pharmacologic treatments, the main area I'm going to talk about is antipsychotic medications, because that is the mainstay of treatment for schizophrenia spectrum disorders. And I'll mention a couple of other medications that are mainly used as adjuncts at this time towards the end. So antipsychotics, as I mentioned in the earlier slide, their role is really to try to reduce the positive symptoms, those hallucinations, delusions, disorganization, all of those kind of intrusive experiences. Now, sometimes, and I think this might be more of an issue sometimes for doctors early on, we often want to really get rid of the symptoms, right? We think, okay, wouldn't it be great if we just didn't have these symptoms anymore, totally got rid of hallucinations? In reality, that doesn't happen very often with antipsychotic treatment, but I want to highlight that that doesn't mean that the treatment isn't successful, because what matters is not whether or not we get rid of every single delusional belief that a person has, or that they never hear a voice again in their life. What matters is that they're not suffering, they're not experiencing distress, and they're able to do what they want to do. And so what an antipsychotic actually does is reduce what we call the salience of those symptoms. So you may have heard, if you were at Dr. Adams' talk yesterday, for example, she mentioned this idea of aberrant salience. The reason that people have positive symptoms is something goes wrong in the brain where we attend too much to stimuli that we shouldn't really be attending to, and then we attribute meaning to it. So basically, what an antipsychotic may do is you'll hear people say, yeah, I still hear this voice saying this upsetting thing, but I'm able to ignore it. Or they may still have some belief that something frightening is happening, but it actually doesn't really scare them that much anymore. And they're able to kind of put it aside or manage it enough that they can still engage in treatment and kind of do what they want to do in life. So there's two main kind of overall classes of antipsychotics. I have typical antipsychotics and atypicals. So typical antipsychotics were first used in the 1950s, and that's kind of the first generation of antipsychotics. And then atypical antipsychotics started to come around in the 1990s. And we have, most of these are what would be considered second generation antipsychotic, and then there's some third generation, but I kind of grouped them together for the purposes of this talk and kind of for practical purposes. So I said I wasn't going to talk too much about pharmacology. I'm going to keep this pretty brief and hopefully simple. You may have heard that one of the mechanisms of schizophrenia has to do with dopamine. So basically, when we first started using antipsychotics, we found that the drugs that helped schizophrenia were drugs that blocked dopamine in the brain. They blocked the dopamine receptors. And so that's kind of how we came up with this theory that, oh, schizophrenia must have to do with too much dopamine. So this class of medication is quite good at reducing positive symptoms, but unfortunately, they have a lot of side effects. So the first generation typical antipsychotics block dopamine in a very blunt way. They kind of just block it everywhere in the brain. And unfortunately, because of that, they come with a risk of what we call extrapyramidal symptoms, or EPS, and those are movement side effects, as well as tardive dyskinesia, which is a kind of longer-term movement side effect that can occur. And they can also cause things like emotional blunting, reduced blood pressure, sedation, and weight gain. I have on the right also the forms of long-acting injectable medications for each class, but we'll talk more about those a little bit later. So after, kind of researching for a while, we figured out that things are not that simple. It's not simply that too much dopamine causes schizophrenia. It's more complex than that. And so we started coming up with this second generation of antipsychotics, the atypical antipsychotics. And so you can see this illustration down here. You have this medication, and it's basically acting on a bunch of different receptors. But the thing that they all have in common is they all work also as a blocker of a particular type of serotonin receptor. And what that does is it has a few different beneficial effects, but one thing that it does is it kind of controls also where the dopamine gets blocked. And so because of that, we actually have a lower risk of those movement side effects with atypical antipsychotics. And we also thought when these medications were first invented that they were going to also maybe help with negative symptoms, but unfortunately we haven't seen so much progress in that area. The downside of the atypical antipsychotics is they do have a higher risk of metabolic syndrome, which I'll talk about more a little bit later on. So this is just another illustration showing kind of how atypical antipsychotics work on a bunch of different receptors. So all of the colors in these pie charts, each color is a different type of receptor. You see they all have dopamine, they all have a serotonin 2A receptor, but then they are all a little bit different in kind of how they work on other receptors in the brain. And so, you know, different people respond differently to different drugs, and this is kind of why. I have listed to the right here just a few that are very common. This is not all of them, but I'll just give a brief overview. So one very common and very good antipsychotic is olanzapine or Zyprexa. So it's quite effective. It's generally pretty well tolerated, but it does come with a pretty high risk of metabolic syndrome. So people may experience quite a bit of weight gain on this medication. Risperidone or Risperdal is another very commonly used one, also effective. It does have a higher risk of those movement symptoms, the EPS, than other atypical medications because it's actually kind of similar to Haldol in the way that it acts. And that it can also cause side effects by elevating prolactin levels. And so prolactin is a hormone that can cause basically women's periods could become irregular and stop. It can cause the growth of excess breast tissue in men and women and even cause lactation. And so it's very important for people on this medication to kind of monitor the prolactin level and be checking to make sure they're not getting any of those types of side effects. Paliperidone, also known as Invega, is actually a metabolite of risperidone. So when risperidone breaks down in the body, at some point in that metabolism, it turns into paliperidone. And so that was made into its own medication. And one of the benefits of paliperidone is that it's available in a lot of different long-acting injectable forms. And then quetiapine is Seroquel. So that's a medication that is also used actually in bipolar disorder, bipolar depression, for mood stabilization. It has a moderate risk of metabolic syndrome. It can also be quite sedating. You will also hear that atypical antipsychotics are used for a lot of other things besides psychotic disorders, and we're not going to get into that today, but just throwing that out there because you may have seen these medications used for other reasons. And then the newer agents, the quote unquote third generation agents, have a slightly different mechanism as well. So some of those, instead of just blocking a D2 receptor, they're what we call a partial agonist, which again allows that blockade to be more selective. So it's not just this blunt blockade that's going to cause all these different side effects. It's trying to be more targeted. So the most common one is Abilify. And that actually can reduce prolactin and can be used to reduce the side effects from a drug like risperidone. I have some others listed here, Rexulti, Vraylar, Caplita. I'm not going to go too much into those. We don't have a ton of kind of data on them because they are newer. So yeah. And then we have Clozapine. So Clozapine, there was a talk kind of talking about Clozapine blood monitoring yesterday. So this is actually our most effective antipsychotic. It really stands out in terms of its efficacy, and it's also an FDA-approved medication to reduce suicidality. So it's really good in people who have a high risk of suicide. It doesn't get used as often as it should because there are some barriers to treatment. So there are requirements for blood monitoring when you're on the medication for blood levels because it can reduce a type of white blood cell, and it can also cause some other serious side effects. However, And NPRC does a lot of research on this. We know that if we use it properly and we start at low doses and titrate people up slowly, it can be used safely and it can really be life-saving. It is the first-line treatment for treatment-resistant schizophrenia. And so NPRC has done a lot of work to try to break down the barriers to the use of this medication because it really can be life-saving and life-changing for people who need it. So that was just a brief overview of the medication classes and some of the individual medications in each class. So I want to talk now a little bit about how do we decide what medication we're going to give someone? What are the factors that we take into account? So I have 4 main classes here: efficacy, tolerability, formulation, which has a lot to do with adherence to medication, and then last but not least, patient preference. So talking about efficacy, basically typical and atypical antipsychotics show similar efficacy for reducing the symptoms of schizophrenia spectrum disorders. This graph here on the right, basically the bars show like the change in symptoms. And so to the left is better because it means there's a reduction in symptoms. And we see here Clozapine way out ahead is the only one with a really kind of significant difference in efficacy. The second one is a drug that is not available in the US, unfortunately, amisulpride. Then we see olanzapine, which usually does pretty well, risperidone, paliperidone. So kind of the 3 that I had listed earlier. We have Haldol here, Seroquel, and Abilify, and then some others as we go down. So really, they're pretty close together, except for Clozapine. I mentioned here there's a big famous study called the Katie study that it compared a lot of different antipsychotics to one another. And one of the outcomes was time to discontinuation. So how long did it take someone in that study to drop out of the study or need to switch to a different drug because the drug that they were on wasn't working, or they didn't like it, they had too many side effects. And olanzapine had the longest time to discontinuation in the Katie study, showing that it's pretty efficacious and very well tolerated. The next factor is tolerability. So atypicals do tend to be better tolerated as compared to typical antipsychotics. Again, talking about like the Katie study, and there's actually the graph of that here. Olanzapine did the best. It may be relatively better tolerated among the atypical antipsychotics. But I do want to make the point that what's tolerable is very variable and very individual. So for providers, we need to be thinking about, not what drug would we tolerate the best. We need to talk to our patients and find out what matters to them, what side effects would be the most intolerable to them, and work together to kind of figure out which medication is going to have the best tolerability. And next is formulation, and this is where I'm going to talk a little bit more about long-acting injectables. So basically, this is a list of the long-acting injectables available for different medications. So at the bottom, we have Haldol and fluphenazine, which is Prolixin. Those are first generation. And then we have second generation LAIs up here. So long-acting injectables have gotten really popular, and I think a lot of physicians and prescribers really like them because if you give someone a long-acting injectable that works for 4 weeks or 8 weeks, we know that the person is on their medication, right? That they can't forget, they can't stop taking it. So we eliminate the need for daily dosing, which some patients actually really like as well. And then we might reduce relapse, we might reduce rehospitalization. And so that's really important. There can be some benefit to having to kind of come in and get an injection, and that the patient is going to be interacting with the treatment team more. There's a reduced overdose risk because you're not going home with a month's supply of medication that would be unsafe to take all at once. And sometimes there can be more stable blood levels of the drug over time. And so for that reason, there's a lot of excitement around their use. They've been studied a lot in recent years, but there are also some cons that we need to be thinking about as well. So the first one I have here is that there's actually a pretty limited selection of agents. So when we look at the second generation specifically, this list looks really long, but I will make the argument that it's essentially only has 2 drugs on it because These first two up here are both versions of Abilify. These are all versions of paliperidone or Invega. And then risperidone turns into paliperidone when it's metabolized. So these are pretty similar. And then olanzapine I have crossed out because while a long-acting injectable form does exist, it unfortunately is kind of difficult to use really from like an administrative standpoint. So there's a risk of, with the olanzapine LAI, of a post-injection syndrome that can cause sedation, ataxia, seizures. So it's pretty serious if it occurs, but it's also quite rare. And basically, in order to use this, you have to have a person then sit and stay in the clinic for 3 hours after receiving the injection. The physician needs a special waiver to be using it. The clinic needs a special waiver. So effectively, like even though we have this option, which could be really nice for a lot of people, it's just not used in very many places. Other issues that can occur with long-acting injectables, there's less flexibility to adjust the dose. You can't discontinue it. So if someone starts it and they don't like how they feel or they have side effects, you can't really stop the medication because it's a long-acting. You're just going to have to wait kind of till it's worn off. And then there's some reduced autonomy. You know, some people would prefer to be making the choice to take a medication themselves every day, and that matters. And finally, patient preference. And I have this all in caps because I think it's really, really important. And I think that unfortunately, sometimes when people, especially for people who are very sick and may have a difficult time communicating with providers or communicating their preference, I think that this can sometimes get overlooked. And I also think it's always really important to remember, like as providers, we're very used to prescribing these medications, but we're not the one going home and taking it every day and taking it potentially for a very long time or even the rest of our lives. So why are the reasons why someone might want to not take a medication or might stop their medication on their own? So patients might not think that taking medication is necessary. So you may know or have heard in other talks that people with schizophrenia spectrum disorder sometimes don't have insight into the fact that they have something wrong that requires medication. So why would you want to take a medication if you didn't think you needed it? Sometimes the medication just doesn't work. You know, with psych medications, unfortunately, there's a lot of trial and error. We don't know which medication is going to work well for which person. And so when we start treatment plan for someone, it can be a really difficult process of trial and error. And I think it's really important to remember that, you know, starting a medication, waiting to see if it works, you know, dealing with side effects if you get those, finding out it doesn't work, having to start over, that process is really, really difficult. And we need to be really mindful of that and really be good partners with patients through this process. Side effects obviously make someone not want to take a medication. Psychiatric medication can be stigmatizing. So, you know, that can be a barrier for people. Lack of trust in providers, that can be a barrier to taking medication as well. And in fact, for people who do lack insight into their illness, the number one factor that actually leads to medication adherence is a good relationship with their treatment provider. People might say, I don't really know why I need to take this, but I trust this doctor and they think that it's good, so I guess I'll do it. Psychosocial factors. So, you know, maybe people don't have somewhere stable to live. Maybe they don't have a way to get to the pharmacy. Maybe they don't have stable employment and a stable schedule. There are a lot of things that can get in the way of taking medication and taking good care of your health. And then cognitive factors. You know, as I mentioned, people with schizophrenia spectrum disorders might struggle with memory issues or attention issues. Or if they're having a lot of positive symptoms, that can make it difficult to kind of keep track of things. And so that can get in the way as well. So how do we address these different barriers to taking medications? So in terms of patients not having insight, you know, a patient may not think that they have a psychiatric illness or something called schizophrenia, but there might be something that is bothering them. So we have to kind of say, okay, like what does the patient want help with? maybe they feel really anxious as a result of the symptoms they're having. Maybe they're not sleeping. A lot of patients I talk to, when I ask them, why do you take the medication? Like, what do you like about it? Will say, it helps me think more clearly. And so it's really important from the provider end of things for us to remember that, what we think is important to treat might not be the same thing that the patient thinks is important to treat. But usually we can find some middle ground where there's overlap, and that's a really important strategy to take. I mentioned before, if a medication isn't working, that you might have to go through a trial of several different agents to find one that does. Side effects, I'll talk about managing a little bit later, but we might change the med, we might treat the side effects. For stigma, educating providers, educating families about the illness, using destigmatizing language when we talk to patients, and also when we write notes, because patients can see their notes, but even if they're not looking at them, it matters how we write about people, because that also can be a place that we fight stigma. In terms of lack of trust in provider, obviously we always work to build a therapeutic alliance with patients, but team-based care is also really important. And, maybe a patient doesn't really want to work with me, but they really trust someone else on the team, and that person might be the person to kind of get through to them. To address psychosocial factors, we have a lot of services like ACT teams, so assertive community treatment teams, case management. There's other types of wraparound services available for people with serious mental illness. And for cognitive factors, enlisting supports at home if we have those available. Again, like ACT teams are really helpful for medication adherence. Things like long-acting injectables or pill packs can also help with remembering to take medication. And I just have this slide here, it's a brief story. So I had a patient on an inpatient rotation a few years ago who was admitted over the weekend, and the weekend team had talked to them about starting medication. This was someone who had chronic schizophrenia and had been on and off medication over the years. And so they really wanted to start this patient on an LAI. They wanted to start them on a medication that could transition to a long-acting, because they said, this guy's gone off of his meds before. The best thing for him is to have the LAI. And he really didn't want the LAI and kept telling them that he wanted Zyprexa. And I wasn't there for these conversations, obviously, but the way that it was documented basically said, this patient's requesting Zyprexa, but they're not really giving a good reason why they need that medication as opposed to the one that we want to give. And so I came in on Monday. I had this patient on my team for the week. And I talked to him, and he's kind of still said the same thing. He wanted Zyprexa. And I said, okay, why do you want Zyprexa? And he said, I just feel better on it. And I tell this story just because it really struck me, because that seems like a really good reason to me, right? And just as a reminder that we really always need to be mindful and curious and be asking kind of open-ended questions about our patients' experiences to figure out what they value and what matters to them. So I'm going to talk briefly about managing side effects. So there are a few different principles that we use to deal with side effects of psychiatric medication. The first is to start low and go slow. So when we're starting someone on a new medication, basically, we want to start at the lowest dose we can and increase it very slowly. For a lot of medications, side effects are going to be the worst at the beginning of the medication or when we do a dose increase. And so by doing the start low, go slow principle, we can sometimes avoid that, which is really important for two reasons. One, we don't want to be subjecting people to side effects unnecessarily. But two, we don't want to give someone a horrible experience with a medication and then they're scared to try another one, or they're scared to try that medication in the past. Basically, you don't want to be burning bridges by kind of hitting someone with a high dose of a med if it's not necessary. Step two would be to maybe adjust the dose or the dosing schedule. So if it's possible, if there's room to decrease a dose of a medication and that's safe to do, we can think about that. Or the dosing schedule. So a lot of medications can be sedating, for example. So if someone's taking a sedating med in the morning and at night and they're tired all day, then we might just give the whole dose at night when they're going to go to sleep. If those things don't work, you can think about changing the medication to a different agent that might be effective and have fewer of the side effects that we're targeting. And if not, if the person needs to stay on that medication or they are doing well on it except for particular side effects, then we might treat those side effects with additional medications or sometimes like lifestyle interventions. So this is kind of oversimplified, but basically I have down at the bottom, we know that those typical antipsychotics cause more of the movement side effects. And then the atypicals, we see more of the metabolic syndrome. However, you can see all of these in either class. So they're not really divided like this, but I just kind of split them up this way for this graphic. So I'm going to go through kind of each group of these and then how we treat them. So for the movement side effects, I have a few different types here. So acute dystonia is basically kind of a muscle spasm, and that can occur really just even with one dose of the medication. It's something we'd see very early on. So people might have like a spasm where their neck turns and then it's kind of cramped and they can't move it. Or there's something called an oculogyric crisis where someone's eyes might be deviated upward and they have trouble moving them. So those are treated pretty effectively with antihistamines, so Benadryl, or anticholinergics, so Cogentin, Benadryl. Can use amantadine sometimes for EPS. And then people can develop Parkinsonism on antipsychotic meds as well. So those are basically symptoms that kind of mimic Parkinson's disease. So people might have a tremor or stiffness in their limbs, or what we call a shuffling gait, where their gait kind of, they don't like lift their feet and kind of shuffle. And again, those would be treated with things like Benadryl, Cogentin, amantadine. And then there's tardive dyskinesia. So tardive means delayed. Dyskinesia is abnormal movements. And so when people are on antipsychotics for a long time, there can be some changes to like the dopamine receptors in the brain, and it can lead to this long-term movement side effect where folks might have kind of like writhing movements of the mouth or the tongue, sometimes other parts of the body. And this, unfortunately, does not always go away when medication is stopped. There are a couple of medications listed here, valbenazine, deuterbenzine, that are in a class called VMAT2 inhibitors that treat those side effects. But we would also keep a really close eye on people and make sure that they're not developing EPS. Akathisia is basically a form of really extreme restlessness, and restlessness really doesn't do it justice. Basically, people will describe this feeling of inner restlessness and needing to move, and actually often will be moving constantly to try to alleviate it. And this can actually be really, really quite severe. Like it will increase suicide risk if not treated, because it's very, very distressing to people. But there are quite a few things that we can use to treat it. So beta blockers, so meds like propranolol, benzodiazepines, so that's meds like Clozapine or Ativan. Vitamin B6 has been shown to be somewhat helpful with this. There's a medication also called mirtazapine or Remeron. That's an old antidepressant that sometimes helps with these side effects as well. Anticholinergic side effects. So basically, that's like a class of side effects that are kind of drying overall. So people might experience constipation, urinary retention, dry mouth, blurry vision from their eyes being dry. So we'll treat this with laxatives, sometimes hydration. You can get low blood pressure and antipsychotics. Also, hydration can be useful for that. And then for metabolic syndrome, exercise, diet, and metformin actually can be quite useful. So it's a diabetes medication. So one question is, do we wait till these side effects develop to treat them, or do we try to prevent them with prophylaxis? So it depends on what we're talking about. So for extrapyramidal symptoms and tardive dyskinesia, the general consensus is that there's really not a benefit from trying to use anticholinergic medications as prophylaxis. And there's some risk actually that long-term anticholinergic use could increase the risk of TD. So for those movement side effects, we really wouldn't put someone on a daily anticholinergic necessarily unless they've had those side effects actually. For metabolic syndrome, which is listed here, there may be reason to give meds prophylactically. So metabolic syndrome is not just weight gain, it's basically visceral obesity, so obesity in the stomach and around the organs, high blood pressure, insulin resistance, high triglycerides or bad cholesterol, and then lower levels of the good cholesterol. So metformin has actually been shown to improve all of those parameters in antipsychotic-induced weight gain. And even better when combined with lifestyle interventions. And there are several studies that show benefit when it's started early in the course of treatment, so during the first episode. I also have down here a new drug called Lybalvi, which is olanzapine or Zyprexa with samidorphan, which is a medication that's thought to potentially help prevent weight gain. There's really not much data on this. It's pretty new, but that's something that's been developed. Just a couple other brief considerations. So I mentioned how antipsychotics are best really for positive symptoms and that we might see some improvements in negative and cognitive domains with the atypical, but not as much as we'd hoped. There are other mechanisms that we now know contribute to schizophrenia, including something called NMDA receptor hypofunction. So there are other neurotransmitters that work with that receptor that we think are implicated in how the disease works. And then inflammation is also related to schizophrenia. In general, people have higher baseline levels of inflammation if they have it. So these are medications that are used as adjunct. Most of these, or really all of these, are medications that were developed for different things, but they are anti-inflammatory or involved in working with the NMDA receptor. And so we've tried them as adjuncts with antipsychotics, and we have seen some improvement with negative symptoms and cognition. I'm not going to go through all of them because I think we're getting maybe a little lower on time. I'm going to leave time for questions, but if anyone has questions about these, we can go back to it. Lifestyle interventions like physical exercise, nutrition, things like art and music therapy, avoiding substances, especially cannabis, also can show improvements in just overall health, quality of life, and sometimes in the cognitive performance as well. And then psychosocial interventions, you've probably heard about some of these over the last couple of days. This picture on the left is Be More Clubhouse, which is a really, really great community organization where people can kind of go during the day and participate in activities and have community. I have a little graphic down here showing the CBT triangle, which is kind of what Dr. Adams talked about a lot yesterday, and then assertive community treatment or ACT teams that kind of go out into the community and treat patients in their homes or find them, wherever they are. And those can be really helpful as well. This is just another little graphic talking about some of the different psychosocial treatments. And I just have this at the end because kind of as I showed earlier, again, what's the role of medication and treatment? It's to alleviate the symptoms and have that initial stabilization so that we can then get people involved in all of the psychosocial interventions that are going to help them improve functioning and get the quality of life that they want. So just quick conclusion. So medications are a necessary but far from sufficient component of treatment. And our current meds are good at treating the positive symptoms of schizophrenia, but not always so great at the other components. The goals of treatment should always, always, always be guided by the person who is receiving the treatment. And recovery often involves multiple modalities of treatment and multiple support people as well. Okay, and then this is my email. And I'm going to minimize this so I can see people's faces again. Okay, so that's
Wow,
it.
Dr. Kulaga, thank you so much. You have a ton of questions that I'm going to start with. I just don't know where to start, so let me start here with the first one. Kevin asks, for the future, what is in the pipeline for treatment that looks promising?
Hold on one second. Oh, I thought I was muted for a second. Yeah, so I mean, some of these like third generation antipsychotics do work on different receptor profiles than what we've seen before. And so they do show some promise in treating like maybe some of the negative and cognitive symptoms. I think one thing that's going to happen is we're realizing more and more that this is a syndrome that has a lot of different phenotypes. So I think the hope is that, and some of the research that like Dr. Kelly does and that I'm starting to get involved in, the hope is that we can sort of try to tease apart those phenotypes and start targeting treatment better so that we're kind of guiding people more directly to the things that are going to work for them.
Great, thank you. And then the next question is, they're wondering if you could also speak on psychotic depression, treatment of it, management, etc.
Yeah, that's a great question and a big topic, but basically the difference between like something like schizophrenia and then psychotic depression is psychotic depression, the psychosis is confined to the mood episode. And so when someone has a depressive episode with psychosis, we need to treat the mood symptoms and we need to treat the psychosis, but they probably won't need to be on an antipsychotic long term, ideally. ECT is also a really great treatment for psychotic depression, especially when we see in kind of like geriatric patients. People do really, really well with that. I'll keep it there just to keep it brief.
Okay. And then we just had a comment. Myra is saying that she loves your framing of a syndrome with clusters of symptoms that you had earlier in your slide deck. And she said their family has suffered from clinicians not supporting that her daughter has a psychotic disorder because she presents a bit differently. So her family can see some of the things that clinicians don't see. And she's also been labeled with somatoform disorder, which has been traumatic for all of them. So that was in there. And then she's asking if you would say that Johns Hopkins and the University of Maryland have a significantly different view of the symptoms of schizophrenia, and who is and isn't within the cluster of psychotic disorders from a diagnostic approach.
Sorry, I'm just looking in, and who is and isn't within the cluster. So for the first part of your question, I don't really know in terms of schizophrenia. I know one big difference between University of Maryland and Hopkins in terms of our training is we do a lot more training with like trauma and like trauma disorder and informed care, which I think can inform how we look at psychosis sometimes. But to be honest, I don't really have enough experience with Hopkins or folks there to answer that too much more specifically. And who isn't in the cluster of psychotic disorders? That second question is a tough one to really answer. Yeah, I'm not really sure how to answer that. So, I mean, I guess I might pass on it for now and ask if you want to type in clarification of kind of what you mean by the question, because I'm not totally sure how to answer it. Sorry.
Okay, no worries. So we can maybe get clarification for that later on.
Yeah.
Okay, and then we also have Kevin again, who's asking, are the more recently developed atypicals any better than the early ones?
The short answer is no. Maybe we'll see more evidence in the future, but as far as from what I know right now, I would not see a reason to be trialing someone on the newer ones before something like Zyprexa, for example.
Okay, that's good to know. And then Kevin's next question about why Zyprexa was lined through, that was already addressed by you when you were speaking. Lynn's asking, she learned that serotonin is good, so why block it?
That's a really good question and gets it to a very complicated answer. So basically, and this is kind of what we learned in psychiatry, right? We used to think this neurotransmitter does this thing. We either want to turn it on or off, and that's good or bad. And it is way more complicated than that, unfortunately, or fortunately, and it's probably part of why humans can do all the things we do. But basically, like blocking something in one part of the brain isn't the same as blocking in another part of the brain. There's like feedback loops where like blocking something in one part's going to turn something else on here, and that's going to turn like this thing off. So there's all these cascades and like feedback loops and different tracks and areas in the brain where these neurotransmitters work in different ways and might have like paradoxical effects depending on like where it's happening or how much concentration of the neurotransmitters in that part. So the long story short is it's just a lot more complicated than that.
And then Doris is asking for Clozapine. Do you have info on if it increases OCD symptoms?
So it can actually, yeah. So really a lot of antipsychotics do have the potential to do that. It's not terribly common, and it might be in people who maybe would be predisposed anyway. But yes, clozapine and olanzapine can induce OCD symptoms.
Okay, great. And then I actually had a question. What about benztropine for spasms? There's a patient that was on 200 milligrams of Seroquel and has teeth clenching, and they experience body jerking movements like back and forth, and arm movements, and also they'll feel a thumping on their back, and lights flickering when they take their Seroquel at night, and it only happens once they take Seroquel.
Yeah, that would definitely be so. Benztropine or cogentin, which is the same medication, different name, is definitely something that we would use for that. And if someone's just taking something at night too, then it would kind of probably just make sense to take it together, because those medications can also be a little bit sedating too.
Okay, great. That's good. That's good to know then. And that would be akathisia. I guess it's not TD, but it's because it only occurs at night. So, okay. Someone's asking, could you please speak on your thoughts on the use of VMAT2 inhibitors, valbenazine and deutetrabenazine? Yeah, that's a tongue twister. Deutetrabenazine. When should it be initiated? Do patients develop tolerance? If so, after how long? Are there any side effects? Issues to consider with use in the elderly? This is a loaded question. Wow, a lot of parts to it. And how long do patients typically remain on a VMAT2 inhibitor?
So I'm going to be really honest in that I need to read up a lot more on this. So I don't see them used very often, is what I can say, in terms of just residency in the various doctors that I've worked with. That doesn't mean that we shouldn't be using them more. And all of these things are questions that I have as well and have been intending to look up. So I'm sorry that I don't have answers now, but feel free to be in touch. My email's up, and if I find good information, I can let you know.
Okay, thanks. And the next question is, and this is an interesting one too. Someone's asking, how often should a provider be performing an in-person full Ames test to detect the development of TD in a patient on an antipsychotic, especially if the patient's elderly and has been on the antipsychotic for over 2 years? It's challenging because their provider does most visits online, so they don't look at the patient's entire body during the Zoom sessions.
This is such a good question. And I actually, we had some similar questions about patients with catatonia on Zoom sessions too, because you really need to be doing a physical exam. And I would say for anyone in antipsychotic, I think it's good to do them regularly, especially elderly, and being older and female is a risk factor for developing tardive dyskinesia as well. And so I think, we don't have data on this per se of how effective this is, but I think one thing that probably makes sense is if people live with family or other people, if the provider can help teach the people at home kind of how to do some of the physical parts of the exam or what to look for, so that they could work together to complete the assessment on a regular basis. Because that is a problem with telehealth, and it's come up with some other, other diagnoses as well.
Great, thank you. And the next question is from Myra again. Her daughter has Ehlers-Danlos syndrome. It's a chronic illness with defective collagen protein of connective tissue. And so part of the profile is mast cell activation and extra sensitivity to medication. So she wants to know if that profile is problematic for antipsychotic medication.
That's a very, very interesting question. And there's a lot of overlap with Ehlers-Danlos and then autoimmune disease and stuff and psychiatric diagnoses. And it's an area that we are very, very new in understanding. I don't know, to be honest, although I'm very curious now, and I'm going to look a little bit more into this. That's a very kind of specialized area.
Okay. The next question is what your advice would be for dealing with a provider who seems to be underqualified or inexperienced and only seems to be doing the bare minimum in the treatment process of taking care of their loved one. And the example they give is a psychiatric nurse practitioner seems to be in over their head, but there are no psychiatrists in the practice that are available to take new patients, and they're having difficulty finding someone, especially someone who will do a CBT or a deeper level of therapy for an elderly patient with psychotic depression.
Yeah. This is so hard. I mean, this is just like a systemic issue, right? Like that there's not enough access to care, or that there's not enough people who take insurance. And so, it's really tough. I think, obviously kind of asking anyone who you can think of if they know of places to go, or like know of referrals, things like that. But yeah, I don't have an easy answer to this one. I think, definitely follow your gut. If you don't feel comfortable with a provider, then, it's worth kind of looking for someone else. And if it's someone who seems like they'd be open to feedback, maybe having an open conversation with them, or, seeing, but unfortunately there's not a great way to kind of increase access to care. Just, for my individual advice, there's a lot of things that we need to change about the whole system.
Okay, and I think we have time for one more question. You have, I think what we're going to probably try to do is just get all these questions that are not answered. I don't know if we send them to you on email, or I know that there's a little thing here in my script that says that if you didn't get your questions answered, you can also send your questions and the name of the session you attended to connection@namimaryland.org. So connection@namimd.org, or submit your question in the end of event evaluation later this afternoon. So I'm going to do the next one that was put in the queue, and that's what are some keys to deciphering Alzheimer's or other forms of dementia from a psychotic depression? How would you determine if a patient with a psychotic depression who has had success with treatment in the past after a relapse, if they are now developing dementia, how would you diagnose them? How would you treat them?
Gotcha. I'm saying psychotic depression. Sorry, which question was that? I missed part of this. Sorry.
It's the one from Catherine, and it says 12 minutes ago. It has like three different parts to it.
Okay, so the Alzheimer's versus some psychotic depression. Yeah, that's a really great question, because we do see psychotic depression kind of more in geriatric patients. And so, I mean, first off, like having a geriatric psychiatrist is really, I think, key if you can get access to one for someone who does have psych problems in that group. Now developing dementia, top psychotic depression. So yeah, I mean, dementia basically is going to have some different features than psychosis, and so it can be a little bit difficult because when people are depressed, they can have cognitive difficulties and memory difficulties and things like that. And so, yeah, I mean, and they can also have both, right? And so basically, I would say kind of just getting someone with experience, like a geriatric psychiatrist, is really kind of the best way to go. In terms of treatment, I mean, that's going to be different depending on, what the diagnosis is. It does get tricky if you have someone with dementia. Treating the depression can be tough because, for example, you might worry about like cognitive effects with like ECT. Geriatric patients are going to be more sensitive to different medications and things like that. So I hate giving all these answers, and I'm like, there's no like one answer to this, but it's very nuanced. Like what you're describing is a really great clinical question and a really difficult clinical problem, and you need like a lot more information about kind of the specific case and history and things like that. The long story is like it's complicated, and geriatric psychiatry is kind of a whole additional field that people do extra fellowship training and stuff for. So, and this is why, because there's a lot of other considerations that come into play.
Okay, so that's all the time that we have for questions. Because the next presentation at 3:35. So I don't know if you mind staying on for a few more. I don't mind. This is pretty neat. I've never seen so many questions after a session, so the interest is definitely there.
Yeah.
So let me go on, if you guys don't mind hanging on here. Let me see. The next one is, do you have any strategies for encouraging patients to continue to take medications post-recovery? For example, if they've had a second episode of psychotic depression to prevent relapse. And do you have any advice for the family and this patient when they're extremely concerned about the patient? Any advice for the provider, the doctor, the therapist?
We're kind of encouraging the patient to take medication. Yeah, I mean, I guess, you know, it depends on why the patient doesn't want to take medication. I think like the best thing is like, you know, who do they trust, you know, the most that can kind of get through to them. And I think just what I was saying earlier about trying to find common ground, like maybe they don't think that they need the medication for what they need it for, but maybe it has some other benefit that you can kind of use. Also, you know, if they do trust their provider, just like kind of emphasizing like, hey, like you like this provider, you kind of trust them, like maybe you just give it a try. Yeah, I mean, it's really tough. I don't know if you saw, let me see if I can find it. I mentioned this, I don't know if I mentioned it this talk, but the book that Dr. Adams mentioned yesterday, I'm Not Sick, I Don't Need Help. I'm just going to drop this link in the chat so people can see it. So this is really helpful book.
Yeah, that is I've read it actually, and it's by Xavier Amador.
Mm-hmm.
And I know you can get it on Amazon, definitely.
Yeah. Yeah. And so that kind of talks about like understanding the, you know, like the lack of insight and like how to approach these conversations with someone, but kind of being like, you know, if someone doesn't think that something's wrong, being really blunt and confrontational and saying like, no, like you have psychotic depression or whatever it is, and you need to take this med usually isn't going to be the most effective strategy. Like you really have to think about what is real to them, what they believe, where they're coming from, and operate within that framework, which is hard. It's a skill, and it doesn't always work, even if you're good at doing it.
Okay, I'm going to move on to the next question then. The next one is about transcranial MRI studies. Catherine wants to know what they've shown in terms of treating psychotic depression, and has it been shown to be effective? Does the patient need to continue treatment indefinitely to prevent relapse?
You mean like TMS? Is this what that's referring to?
Yeah, transcranial MRI studies. That's what it sounds like. TMS.
To be honest, I don't know too much about it. So I mean, I like, this is more in like mood disorder realm, kind of when you get to psychotic depression, which is not as much my area. But I do know like TMS is showing promise in treating mood disorders. Like I'm kind of excited about the prospects that it would have for depression, and so maybe then psychotic depression. TMS has not shown so much effect in schizophrenia. That's kind of the limitations of what I know about that.
Okay, great. Now the next one's about off-label use of Seroquel, and I've heard of this too. That it's used to treat sleep issues. So, in people with anxiety and depression, how often does it cause long-term side effects like weight gain and increased risk of developing diabetes?
Yeah, so Seroquel has like a moderate risk of metabolic syndrome, so it's not as much as like olanzapine, but it's still there, and a lot of people will still develop metabolic changes on it. I don't really love off-label use of antipsychotics for a lot of things because they do have a lot of health implications. You know, it's not necessarily. And Seroquel, you know, if people have really, really horrific insomnia and like nothing is working and they need it as like an as needed thing now and then, and it helps kind of break the cycle of something like sleep, or, you know, if someone has bipolar depression, maybe it might be a more appropriate med. But my general sense is I feel that atypical antipsychotics are overused for things that are beyond the scope of maybe what they should be used for.
Okay, and this next one here is is there an increased risk of development of Parkinson's or any kind of movement disorders in patients who are treated with methylphenidate or other ADHD medications?
I have no idea, but that's a really, really interesting question. And I just heard of a friend of mine had a case recently where someone was developing movement symptoms in the window, like before they were taking their next dose. And so they do affect dopamine, but I don't know. I'm not really sure exactly how all that works, but that's a very, very interesting question and something that I've been meaning to look more into. it's not common. Like, it's not something like, when we learn about these medications in med school or residency, we're not like taught about like movement side effects, but there is a possibility based on how they work. And I have heard like a couple of like random cases.
Okay. Now the next question.
Very advanced questions.
This is good. Like, so much interest. I like this audience is on fire. This is great. So the next question, I kind of saw a similar question in chat. So we'll probably cover two of the same questions. And it's about someone who's stable. And this Elizabeth's asking about a 40-year-old male. If they're stable, especially if their schizophrenia is like waned off in their 40s kind of thing, or it's just stabilized, can medications be decreased at that point?
That's also a really good question. So the answer is maybe. So there's a lot of different things that you want to take into account, right? Like, what was going on when they went on these medications? How long ago was it? If it was something that they had like horrible episodes and it was like life-threatening stuff, that's a consideration. If they've only been stable for a short period, that's a consideration. If someone has been stable for like years and years and years and years, then with your provider working with you, you could consider a reduction in medication. What we know is that stopping medication quickly is a very, very, very bad idea. And we don't have a lot of data on like what we would call like deprescribing, so like reducing or stopping medications, unfortunately. But from what I know about that, you have to do it like excruciatingly slowly. So like my advice would be to anyone interested in that, well, do it with your doctor, but I guess my advice to your doctor would be like, do it like 10 times slower than you think you need to, with like minute decreases, and really, really, really close monitoring. So basically, if it is something a patient wants to try, you have to kind of look at the factors. Is it appropriate? And then if you're going to do it, you have to be very systematic and very cautious about doing that. Okay,
great. And then this is really going to be the last question because we only have 5 minutes till the next session. If someone already has OCD, does that contradict their being able to take Clozapine?
Not necessarily. I mean, it would be like a consideration, right? Because there is the risk of it causing or increasing OCD symptoms. But if someone's being trialed, if there's consideration for someone to be trialed on Clozapine, my guess is that they've been pretty sick and other things haven't been working. And so it's probably worth a try with like very close monitoring if all of that is the case. So not an absolute contraindication.
Great. Well, thank you so much for your time and for hanging on for the plethora of questions
thanks for all
here.
The questions. I have a lot of stuff to look up. Honestly, like these were like very, very advanced questions. These are great. I'm going to learn a lot from like researching the ones that I could not answer.
Well, it's always great when you can have a presentation in an audience where the learning goes both ways. So this is really, really terrific. And I thank you for such a great presentation. And like I said, this is all the time that we have. And if you were not able to get your question answered, again, I'm going to remind everyone that you can email your question to connection@namimd.org, or you can submit your question at the end of the event evaluation later this afternoon, so that we'll get to the correct place. So again, that's all the time that we have for now. And I thank you all for joining us today, especially Dr. Kalag. I know she probably has a really busy schedule. And at the end of the